talking about racism in the medical profession with nurses from around the world, also American nurses. We will talk about the white heroism and the black rescue and the white rescue in nurses when patients see particular nurses from their own point of view. We'll also talk about panic versus follow-up and follow-through with some of the disease processes like cancer and HIV, which are the two most paramount and most difficult diseases to understand and treat. We'll talk about the nursing challenges within a hospital institution and within home care. We'll also talk about the doctor's final choice that they make from a nursing diagnosis or a nursing assessment. We'll talk about emergency room triage, admitting process, the long or short-term stay in a hospital facility, the practitioners that come to see you and assess you and make diagnoses. We'll talk about the facility, how it relates to the outside, your home care services and who has control over that, and the treatment that extends from the hospital on your discharge. We'll talk about the facilities that are related to your discharge and how the treatment will follow from the inside of a hospital or clinic. I've experienced some very, very messy stuff coming from out of some of the facilities where hospital readmissions are on a rise because of the present practice and present policies that may exist for hospitals under the guise of insurance companies and how they have to move you out quicker, on how they won't get paid for their services but a one-time fee if you're in an extended stay. It's really a convoluted experience, but we'll give you scenarios. One of the scenarios that I will give you today will be a personal one from a patient of mine who experienced what I call a domino effect that leads you into rehospitalization. What happens in that particular diagnosis or multiple diagnosis on how convoluted that can be, and whether you're followed by one practitioner or not, most of the time it is either broken because of the lack of follow-through in the nursing care. And the nurse that actually admits a patient in a hospital loses that contact depending on the continuum, especially if you're admitted from an emergency room. If you're admitted in a hospital from an emergency room, you'll be seen by a hospitalist, or which are medical doctors. You'll be seen by social workers, if need be, if you fall into certain categories of not having any insurance, which a large percentage of Americans and non-American citizens don't have today. Even the working class, many of us do not have the ability to have or afford a monthly PPO or HMO at the rates that are being charged now. And the co-pays are phenomenal and the deductibles are phenomenal. For the average household making anywhere between $30,000 to $70,000. It has risen over the last 10 years I've seen, with many of the hospitals cutting your stay to a minimum, which has caused a lot of readmissions to the hospital. My goal is to have more nursing involvement on especially a continuum, because nurses spend the most time with the patient. Nurses make nursing assessments and diagnoses that generally are not always applied. In the scenario that I'll give will show you exactly how these breakdowns happen. Welcome back. I also want to talk about the facility level 1 scenario, and what Magnus status through the American Nurses Credentialing Association, how it gets awarded, how a hospital's set of nurses are viewed. We'll talk about that. We'll have nurses talk about that themselves, because we have some great nurses out there. We have nurses that are not being utilized with all of its capacities as they should, because of the dichotomy between the medical profession and the nursing profession. Estheticians, they are also able to make assessments that may not be followed by their medical provider. One of the issues that stand strong for me is in this scenario that I'll give, how the person was discharged and was readmitted, inability to have the nurse's opinion match the doctor's assessment and the clinical reason given. We'll be looking forward to strengthening nurses' strategies within the medical profession and their opinions. We're also looking to strengthen the nursing outcome during collaboration with other practitioners within the continuation of your diagnosis. We also think that the CEO of a hospital should be a nurse. The nurse is the emergency room, which is the heartbeat of a hospital, on into the cardiac ICUs, the medical ICUs, the pulmonary ICUs, respiratory. All of these ICUs must be run by nurses. Nurses at the bedside during a practitioner's procedure is also very important to know the full outcome of the patient's performance during that procedure. The patient's performance, the patient outcome, because some bedside procedures are done invasively, and if the nurse is not there and there's a mistake that happens, it's very difficult to be handled clinically. Reporting the medical profession is almost unheard of. They do have in Magnus status hospitals where you can make anonymous phone calls, some nurses, but generally that jeopardizes your position. One of the main topics in this scenario that I am going to talk about is upon the discharge on this patient, on how the readmission happened. Our scenario for today is going to be a 33-year-old black American male who presents with a left chest wall pain, spitting up blood, which is called hemoptysis. He's coughing, chills, fever for 2 days. The fever was 102. The cough had a small amount of blood in it, and the antipyretics worked. It brought down his fever. He has a history of anemia. He was admitted to the hospital, and admitted, he has an EKG, placed on oxygen. He has blood. He has cultures, blood cultures done as well. No hydration. The antibiotic that was given for the second treatment, because the first treatment didn't work, is called, well, the patient is admitted, and then an EKG is ordered, labs are ordered, blood culture brings in a previous CAT scan that said it had pneumonia with pulmonary hypertension. The week of an azolid was given for 1 week, 5 days, that made the patient worse. The patient was then placed on a fluoroquinolone. That antibiotic was more specific and can be given after a first-line treatment. And this particular drug then began to work via IV. I want you to tell me from that patient's admission in this particular scenario what you think should have came out of it. Now, I want to tell you from the patient's first admission, what the type of doctors the patient should have seen, what the consult should have been. I want you to tell me what treatments should happen right now and what the nursing diagnosis should be. In addition to what the nursing treatments should be with medications and comfort. We have, the first question was, what doctor should have the patient seen? What is the consult? A cardiologist, an internist, and then followed by their practitioner, which is true. Now the cardiologist would have examined the heart, and then you'll tell us what tests they should have had, and then the pulmonologist should have been ordered but was not ordered, and you're going to be able to tell us why. Whether or not that was a consult but never was for the anemia. And then we have the primary physician, the internist, and the medical provider that's assigned to them through their insurance company or their choice. Those are the consults that should have been ordered. There's two that were not for this particular patient that had to return to the hospital for further treatment. The nurse always asks for the allergies. The doctors, everyone asks, what are your allergies? But what should be included in there as well is, are you on any other medications or herbal substances or diet plans that might interfere with the medication that we're about to prescribe? And there's a whole lot of avoidances like driving and alert procedures that you don't want to do when you're on this particular medication. The sunlight you want to avoid. But in particular, if you're a pregnant woman, they don't really know the study of the drug, but it is a first-line drug after having no response to a previous drug that can be given. And for the IV, one of the main things about the IV that you want to pay attention to is that the drug given IV, the cultures should have been taken, should be taken, but the drug can still be given. And checking on the duration of the pneumonia that the patient had. How you do that is just ask the patient, you know, how long have you been having difficulty breathing? How long has this been going on? Is it something that just happened, or has this been something you've been avoiding in coming to the hospital? To know the duration of what the treatment should be for acquired or an acute bacterial infection in your lung should be given, like pneumonia or sinusitis or bronchitis. Welcome back. We're at our close of the show, and I wanted to tell you guys a little nursing joke, and I have a couple of them here for you. It says, you know, when you're a nurse, when you're discussing dismemberment over a gourmet meal, seems perfectly normal. You know you are a nurse when you compliment a complete stranger on his bed. You know you're a nurse when you're betting on the alcohol level of alcohol. You know you're a nurse when you find yourself betting on someone's alcohol. You know you're a nurse when you know that KY jelly is optional. This brings us to the end of our show, and I want to say thank you for joining me, and God bless.